I'm Dr. Pallavi Prasad, Assistant Professor Nephrology at Safdarjung Hospital. And today at ISOT EduConnect, we'll discuss a very interesting case presentation. First of all, I would like to introduce and invite all the panelists to you. The speaker today will be Dr. K.C. Gurudev. He's the Director Nephrourology Center of Excellence at MS Ramaiah Medical College and the Chairperson Indian Society of Nephrology Southern Chapter. He has many credits to his name, and he has been the president of Southern ISN previously as well, received multiple awards and accolades. So he'll be presenting the case today, and we also have three senior panelists with us to discuss this case in a more interesting way. First of all, we have Dr. Sampath Kumar, who's the senior consultant nephrologist at Meenakshi Mission Hospital, Madurai. He is the president-elect of Asia Pacific Society of Dialysis Access, and also he is the vice president of Avatar India. Sir has done a lot of work in PD, and he was the past secretary of PDSI. We also have Dr. Himanshu Verma with us, the head of Department of Nephrology and Renal Transplant at VMMC and Safdarjung Hospital, New Delhi. He is a past executive member of DNS, and he has a lot of interest in transplantation. He has multiple national and international publications regarding the same. And of course, we have Dr. Mahesha Venkalakunti, senior consultant nephropathologist at Manipal Hospital, Bangalore. Sir has helped to develop a referral center in nephropathology at his hospital, and he is an executive member of the Indian Society of Renal and Transplant Pathology. So without much delay, I think we'll start with the case presentation. Dr. Gurudev, will you please go ahead?
Dr. Pallavi, let me share my, I don't know whether I call it a pleasant experience or a very exciting when I look back. Can you all see my slides? Hello?
No.
Can you see the slides?
Not yet, sir.
1 second. Can you see the slide?
Yeah.
Yeah. Let me go through the case very briefly. I had one female patient about 42 years who had presumed chronic tubular interstitial disease, was on dialysis for 5 years with me, one of those very loyal patients of mine who used to come very repeatedly with volume overload, and she was on ventilator on more than 2 or 3 occasions, came out of those crises from ICU. Sometime in 2012, she developed tubercular lymphadenitis, which was treated adequately. She had 2 children, both of them were teenagers, and she didn't want to take kidney from them, and husband volunteered. He coincidentally had the same blood group. Unfortunately, when I checked their cross match on 2 occasions in May 2011 and August 2011, both times it came positive for donors, cross match positive. So I just looked up the literature. Those days we used to use azathioprine to desensitize, not knowing how it would work. So I just gave her azathioprine 100 milligrams daily for 6 months. And presently I was surprised to see she had turned cross-match negative in March. And again, I waited for some more time. And in August, again, it came as negative. That's when I thought, let me check donor-specific antibodies, and it was reported as class 1 antibodies. I presume it was more than 1000 MFI, though they didn't mention about it. It was done from TTK lab, so it is quite a reliable report. So I thought we should desensitize this patient before we do any transplant. Though the literature says class 2 are more important than class 1, but when I went through the literature, even class 1 has got similar risk when it comes to acute antibody-mediated rejection. So I gave her rituximab 500 milligrams on 13th of August, followed by plasmapheresis on subsequent 3 days. Low dose IV IG was given. And I wanted to cross-check, sent the sample to transplant immunology lab at Mayot Hospital, Chennai on 18th. And MFI value was less than 13 for both class 1 and class 2, HLA class 1 and class 2. So we scheduled the transplant on 21st of August. And meanwhile, coming to the donor details, he was her husband and he had no comorbidities. We got the all the permissions. Those days we had to send even these people to authorization committee for permission. And we scheduled the transplant on 21st of August 2012. So this is the donor angiogram. This is a flush iotogram where you can see both the renal arteries on flush. So coming to the selective renal angiogram, this was the left renal artery, a single vessel. Then the right one, which was also a single vessel, full nephrogram was seen. So we took him for surgery. A lap donor nephrectomy was being done. Just when you were about to cut the renal artery, the clip which was used, that hemolock clip, it slipped from the aortic end, and we had to convert the surgery into open surgery. Meanwhile, patient had severe hypotension. We had to pump in blood and saline. Anyway, he was stabilized and kidney was taken out and given to me. I perfused it for about 15-20 minutes and took it to the recipient side. This is the surgical, what happened surgery that day. It's a video of the surgery. Why it's not playing. One second, I don't know, it's got stuck. Sorry, 1 second, something went wrong there. Are you able to see the slides?
Yes, sir, we can see them.
Yeah, let me show this. So this is the lap surgery being done. The hemolock clips are being applied. Let me go to the other side. Yeah, see, already 2 clips are there. This is the renal artery and the vein. This is when the surgeon is cutting the renal artery away from the clip. This is when the disaster happened. And the clip came off from the aortic side and it was flooded with blood. Then the surgery had to be, it has to be converted to open surgery. Then coming towards let me switch over to the recipient, what happened. Leave the donor there. Recipient was doing well. She was making around 400 to 500 ml of urine per hour on the first post-operative day. But next day morning, her output started dropping early morning. It came down to 15 to 20 ml. And by the end of the day, she became almost anuric. The Doppler showed reduced flow, peak systolic flow, and there was absolutely no end diastolic flow at all on Doppler. So by the end of the day, I spoke to Dr. Mahesh and said, I'm sending one biopsy. I need report urgently. So I did a biopsy around 5 in the evening and sent it to Bangalore same night. Next day morning, I got around 12 noon, I got the report, which said that kidney had glomerular fibrin thrombi and glomerulitis suggestive of antibody-mediated rejection. C4D negative antibody-mediated rejection. There was glomerulitis, there is acute tubular injury, and thrombotic microangiopathy. Yes? Yeah. So meanwhile, let me switch over to donor now. now the recipient has developed antibody-mediated rejection. She hardly has any output, and the donor started having hypertension. His blood pressure was 170 by 110, and he was absolutely anuric. I just wanted to rule out some obstruction, did a ultrasound, but I tried to look at the right kidney, but I couldn't get a proper window because patient was not able to hold his breath. So next day, the second post-operative day, he was still anuric. Creatinine had gone up to 4.7. And somehow I managed to do a Doppler which shows reduced blood flow. The day 3 again, his creatinine jumped to 9.7. I'm talking about the donor now. His creatinine was 9.7. Hemoglobin had stabilized. There was no further bleed anywhere. And what I thought is this is very unusual. Some tube has blocked. Now he has got one kidney, and I couldn't find any hydronephrosis. So I thought I should do a renal angiogram. So this is for when I did a flush, we couldn't trace the renal arteries, both sides, which came as a real shock to me. This is the clamp on the left renal artery, you can see. Then we tried to find out the right renal artery. You can just see the stump, and no dye was going into the right renal artery. So it was obviously the right kidney was completely blocked. So now I have a very unusual situation. The recipient is anuric because of AMR, and the donor has developed severe renal failure. And I couldn't find the kidney on angiogram. So I didn't know what to do. I just called my friend Dr. Sundar saying this is a situation. He also was wondering what to do. Then I called Dr. Ballal. He also said this is very unprecedented. He has never heard of this. Then I spoke to Dr. Pathak, Vivek Pathak in Coimbatore. I explained what he said. Why don't you take the kidney back from the recipient and put it back to the donor? I couldn't even imagine doing something like that because the recipient had antibody-mediated rejection. I didn't know what to do. Anyhow, I thought this was the only way to prevent both of them being on dialysis. I said, okay, let's talk to the family. So family were quite, though they were very loyal patients of mine, the minute I came out of the OT and said that the donor had bleed, from that moment he has been recording my conversation. Later on, I realized he has recorded 400 my conversation. He had 400 CDs with him of my conversation. And then the Ballal suggested, see, this amounts to another transplant. So you have to ask the authorization committee. Fortunately, everybody sitting in authorization committee and competent authority had no clue about what rejection was and what transplant or auto transplant. One of the members said, no, yeah, it's a fantastic decision. We should take the kidney out and put it back on the donor. I just needed that word from them. Then with difficulty, I took the consent from the family. They were asking so many questions. How many cases you have done? How many such episodes have happened in the past? Somehow with great difficulty, we could get the consent. And before I took the kidney from the recipient, I wanted to see how the kidney is in the recipient before we opened the donor. And when we opened, kidney was quite turgid, enlarged. It looked so tense. I had my own doubt whether it would work when I put it back in the donor. Anyhow, it was removed and I perfused it for nearly 20 minutes to half an hour with cold ringer lactate. I had to make the OT attendant to stand on a stool and tie a BP cuff to the ringer lactate solution to forcibly flush the kidney. Then I took the kidney to the donor side. The bed was prepared on the right eye left fossa. It was transplanted, and I was happy to see it became pink immediately. But there was no urine output for almost 1.5 hours. I didn't let the surgeons close because I was worried whether if something it becomes blue or something. no point in leaving such a kidney there, and it would trigger off DAC or something. Fortunately, it was well perfused, the arteries were pulsating, and at the end of 1.5 to 2 hours to really 2 hours, I could see some urine trickling from the ureter. Then I asked the surgeons to do the ureteric anastomosis. Something told me, let me take a biopsy of this kidney. What is its state? Now that by the time they were completing the ureteric anastomosis, the urine was flowing very freely. Then I took a biopsy, and I was happy when I took a biopsy because the spurt of blood that came out from the surface of the kidney was quite reassuring, suggesting that there has been good perfusion of the kidney. So the auto transplant was done. By the time he was wheeled out of the OT, already there was 600 ml of urine in the bag. So progressively his creatinine dropped, but my nightmare didn't end there. On day 5, the donor developed status epilepticus, and no drug could stop his seizure, and we had to paralyze him, put him on ventilator. That was because his BP had shot up very high, and but he had made around 2.5 liters of urine. Creatinine had dropped to 2.3. Day 6, he was extubated, he was oriented. When I was talking to him, he was looking somewhere else. I asked him, why are you looking to the opposite direction? Then he said, I am blind, I am not able to see anyone. We did a CT brain and found that he had bilateral diffuse cortical infarcts, which was diagnosed as Fress syndrome, and did a Doppler of the transplanted kidney, auto transplant kidney, which showed absolutely normal flow. So day 8, patient was conscious oriented. Creatinine was 2.8, and he started walking. And he said he's able to see now. Some haziness was there, but by the end of the day, he was able to see completely. So just when I was breathing easily, the patient started developing breathlessness. So I did an X-ray. It showed massive effusion on the left side of the chest. Aspirated 1 liter under ultrasound guidance. Patient became comfortable. By then, creatinine was 1.7. Day 19 to 22 was the most miserable time of for the patient and for me, because patient developed severe breathlessness, had to be intubated. X-ray showed bilateral massive pleural effusions. So we decided to put a bilateral intercostal drainage, and albumin was very low. We had to give him many bottles of albumin, and he was on ventilator for 4 days, and he was weaned off later on. And ICD we removed on day 27. Patient got discharged on 37th post-operative day with creatinine of 1 and with antihypertensives. He had normal vision, no neurological deficit. He was walking around. We discharged. Same night, I got a call that he has come back to hospital with severe breathlessness. His hemoglobin was around 7. He had severe pulmonary edema. Fortunately, he settled with IV diuretics, and I transfused 2 units of blood, and after 2 days, we discharged him. Recipient was meanwhile discharged on 5th post-operative day, and she was on regular hemodialysis. I had taken off all the immunosuppressions. And by then, I had forgotten about what had happened to the biopsy I had sent. That's when Mahesh reminded me and sent this biopsy to me, where he said, sir, all the changes have disappeared, and kidney is looking almost glomeruli looking absolutely normal. But for mild tubular injury, glomeruli looked absolutely normal, and there was no thrombotic microangiopathy visible. So that was evidenced by his normal kidney function. And after 1.5 years, I did a isotope renogram, which showed a very good functioning kidney and the right iliac fossa. And I was surprised to see some traces in the native kidney on the right side. And the report said normal functioning transplanted kidney, no evidence of any cortical scars, and normal size right kidney with very poor function. Looking back, I thought when he bled, the surgeon applied a lot of pressure on the aorta through the small window. That's he was already in his early 50s. He must have had some plaques in the aorta, which might have got dislodged and blocked the other kidney. And by the time we recognized, I didn't think it was advisable to open, because when we tried to do angioplasty while doing the angiogram, we couldn't, the interventional cardiologist couldn't go anywhere close to the renal artery. The hurdles were the family were asking too many questions, references, success rate, how many such cases have happened. Fortunately, in 2012 itself, NEGM had published a case report of reversal of FSGS from a live related donor transplant, which they removed and put it in some other donor recipient, where the FSGS, biopsy proven FSGS in the graft had disappeared. I could show only one such case report to them. And there was extensive media coverage in the television and the papers implicating doctors' negligence. And a case was filed in the police station with criminal negligence. And a case was filed in Karnataka Medical Council for medical negligence. And there was complaint lodged in government of Karnataka, and an inquiry was initiated against us. And complaint lodged at state and central human rights commission. And the hospital had to take police protection because of the very hostile behavior of the family and relatives who were very loyal to me for almost 5 years. They had cashless transactions in other hospital, but they wanted to have a transplant only under my care. I think I was destined to go through this. So the questions that I raised were, the Humalog clips that are used comes with a black box warning saying that it should not be used for live donor nephrectomy. Then we did a survey. We sent a letter to all the transplant centers in the country. All surgeons said they are still using Humalog clips for the lab donor nephrectomy, and they are still using them. And we had to take permission from, I just wrote an email to the authorization committee since the time was too short. Does it amount to another transplant? Should we take permission from them? Then comes the medico-legal implication. What if all the patients start asking, now you have made a diagnosis of rejection, why don't you put it back in the donor? So these are the questions that are raised by me to myself. I don't know the answers for most of them. So this is what I published in AJKD as a correspondence, how it all happened. Then I went to the literature. There are only 4 case reports. One is successful reuse of transplanted kidney. This was a patient who had received the cadaveric kidney. Later on, he himself developed intercerebral bleed and brain death, and that kidney was taken out and transplanted to some other recipient, which worked well. Similarly, I just told you about the FSGS recurrence in the graft, which got resolved completely, published in NAGM in 2012. Then again, AJKD has published about a thrombotic microangiopathy recurrence in a recipient. The kidney was taken out and put in another recipient where it worked very well, and there was complete reversal of TMA in the recipient. So this is my story.
Thank you very much, Dr. Gurudev. I think quite an enthralling presentation, and I'm sure you brought goosebumps to each one of us present in this presentation as well. And
Yes, I lost 10 years of my age. I aged by 10 years and lost half of my hair in 35 days. So it was quite a. I should thank the hospital which stood by me and my family which was with me.
Yes, definitely, sir. I can understand it must have been a very stressful period, but I think kudos to you that you changed this adversity into opportunity and you could still salvage the kidney and implant it into the donor despite all the hurdles.
Recipient
I
still on dialysis now. Actually, she has been on dialysis for now 18 years. And the donors, I came to know through my colleague. His creatinine is around 1.5 or something. He's doing well. This is after 13 years of this surgery that happened.
Right.
Okay, now it's open for discussion.
Yes, sir. I would like the panelists to give their comments on this. Dr. Sampath Kumar, sir, would you like to start? Like your comments on the topic and anything you would like to point out?
No, when I heard, am I audible?
Yes, sir, you're audible.
Yeah, when Guru recounted this story to me 10 years ago, it was quite a remarkable Houdini act that he had performed, because I don't think many would have dared to go back and then discuss with the family and explant the kidney and implant it again onto the donor. So it was a remarkable turnaround for the benefit of the donor. And so I thought during a recent discussion last month that this story should have a wider audience. And that was possibly the spark which ignited this discussion. And about the Hemolock, Gurudev, you are right that even today, all the surgeons are using only that. So as I was seeing the video clip, is it possible that the clips were not applied properly before the scissors were applied?
What happened is he had already applied 2 clips.
But was it properly locked?
Yeah, it was locked.
There,
Actually,
some suspicion that the second clip was not properly not locked.
Yeah. I had the similar suspicion. I was in the OT. I told, because we can hear the clicking of the clips.
Yeah.
I told the surgeon, I didn't hear the click properly. He said exactly the same word. He said, Gurudev, I'll put one more clip for your satisfaction. So, in fact, that clipping 1.25 minutes, which is there are 3 clips applied.
Okay.
So, he applied one more clip because I said I didn't hear the clicking noise. So, obviously, when I got a feeling that the one clip has overridden the other clip. So, that caused suddenly when the artery was cut, all the 3 opened up.
Dr. Sampath, you were saying there are like most surgeons they are still using the Hemolock clips. So I think maybe we should use this forum to bring this awareness among surgeons, because I think now in the KDIGO guidelines also they specifically mention that we should not be using this, and I think we should convey this to our surgeons definitely, because
I understand, but I think the metallic clips are not available, if I am not wrong, because they are saying that the only Hemolock clips are available here. I stand to correction, but I would like to have some surgeon who is listening to this to respond to my this thing.
People Hospital has published a paper of 189 donors, lab donor nephrectomy, using, they specifically mentioned they have used Hemolock clips.
Yes.
Yes, so we would request any surgeon who's there in the audience, you can please leave us a mail or put it in the question answer box, and I think we would know better if staples or such metallic clips are available for the use of the same. Next, I would like to invite Dr. Himanshu Verma. Sir, please, can you share your comments or your opinion regarding the case?
I would like to thank sir for enlightening us regarding this unusual, I think, incident or case that happened many years ago. And this was a pure surgical complication was there in nephrectomy, and the courage with which sir dealt with the patient, family, and donor is commendable. And because when we come across such situations in a renal transplant, mainly in the live living donor renal transplant, then we need to keep cool, and we need to explore all the options that we can have. And I think this case will give us a lot of confidence to the juniors like us that we should always keep cool and keep on troubleshooting what best we can do. And this is this is a good example. This is an excellent example of just like I mean to say, sir behaved like a captain cool, MS Dhoni, just like that in difficult situations that he used to do. And as far as that clip is concerned, sir, is it possible that the donor may be having some type of thrombogenicity that he developed that thrombosis?
Investigate extensively. I did all tests, including protein C and all estimations, protein S, protein C estimation. We could not find any hypercoagulable state in him. My guess is because in that panicky situation, surgeon applied severe pressure on the aorta. He might have dislodged a cholesterol, plaque, some atherosclerotic plaque or something into the opposite.
Sir?
Yeah. Yes. I can hear some other noise.
Guru, I also feel that the severe hypertension that he had postoperatively, the donor was also linked to the ischemia of the kidney, and very likely that it was renin and angiotensin were pouring out from that ischemic kidney that was producing all that.
Absolutely right. That's what I could correlate. And
Yes.
the most traumatizing was when he developed blindness.
Yeah.
He became completely blind for almost 3 days. And I was wondering, now I have this donor. I brought him out of this. He landing up in permanent dialysis. Now, am I going to leave him blind for the rest of the life? That was very, very
Yeah.
disturbing to me. But fortunately, God's grace. That's why I keep telling a lot of good souls are around me. And I think they were all praying for me. And he just, third, fourth day, he just said he's able to recognize me. He was a very gentle man. He was but he was constantly telling his children and not to escalate this. But family was hell bent on taking it all for him. It appeared on Hyderabad Times. It came on Ahmedabad Times. It came on front page of Bombay Times, where stories suggesting that husband wanted to save the life of the wife and he himself became a victim, something like that. But people didn't, the press did not appreciate. Though in one of the TV shows, one of my colleague was called to give opinion. He defended me, saying that that was the best one could have done. Yeah.
Yes, definitely, sir. I think sir has rightly said Captain Cool. I think a lot of us would not have had the courage to do that.
I still feel in a transplant program, I keep telling my youngsters, we should keep calm. See, a cardiac surgeon, when he does a surgery, he doesn't panic like us. Because we nephrologists, as our breed, are very sensitive about the functioning of the kidney, of the transplant being always successful. But we have to keep cool. We have to, at the upfront, we have to tell the patient and the family. If someone asks me, all your transplants are successful, I say, absolutely no. I lost kidneys on the first day of transplant. If I say my transplant program is excellent, I am telling the biggest lie. So that makes us feel comfortable, not feel guilty. And we have to keep cool. We should not show that we are also panicked. That's what I keep telling the youngsters, my postgraduates. Transplant is like a marriage. We bring two unknown people to live happily forever. It doesn't happen like that. So while counseling also, I give exactly the about a marriage. It's marriage between the donor kidney and the recipient. Many a times the marriages break on the first day. Same thing happens in transplant also. But most of the people are living happily after marriage, though they are divorces. I compare it to minor tussles, I compare it to acute rejections, which gets corrected by mutual talking and intervention from the elderly. Repeated acute rejection leads to giving up by the parents, and chronic rejection is when the divorce happens. So I compare transplant to a marriage all the time, and patients get convinced about the outcome.
Very interesting take. Dr. Mahesha sir, would you want to talk something about
Mahesh should be telling us more about the. He's the one who gave a lot of hope to me. You know, his report made me to take the kidney out of the recipient. Mahesh?
Yeah, this story is something like listening to one of the rare situations, and as you also mentioned, the Captain Cool, it's difficult to digest when an unexpected thing happens on the OT, like one kidney, you are not able to see the right kidney, and few days later, the vision is gone, and with such a kind of emotional to keep thinking about what best can be done in the interest of patient. So that's a hats off to Dr. Gurudev sir. Like coming to the first biopsy, which had the features of both thrombotic microangiopathy in the gloms. Most of the gloms had fibrin thrombi, and also with the evidence of glomerulitis. The C4D stain had shown 1+ positivity, like less than 10% of the PTCs being positive for C4D. So this was the decision to call it as like in the glomerulitis along with the C4D. Though the TMA could have been for any other reason like iatrogenic, and this was a perfect setting for having that kind of a scenario. But the C4D was positive, so that was a convincing to call it as a acute antibody mediated rejection. That's about the first biopsy, and coming to the later second, the biopsy which was done after the auto transplant procedure, that had completely kind of vanished all the fibrin within the gloms. It was kind of a flushing out all the capillaries and making them patent all throughout. Only finding was that of a moderate degree of acute tubular injury, and the C4D was negative. And I called up sir to say that this is kind of a dramatic recovery in a span of 5 days with a florid AMR. Looking at the second one, I have never seen this kind of a resolution of histologic features. And that's about this patient's, both the biopsies. Yeah.
Dr. Mahesh, if I may ask, like, do you really expect that within hours there can be such dramatic histological changes, or do you think that because rejections are also like patchy processes, so maybe the second biopsy, definitely there would have been recovery, but can it really occur like on the biopsy was an on-table biopsy? Is it really feasible?
No, the patchy process, I agree that it could be a very patchy involvement of fibrin thrombi, but this kind of the second biopsy without having any fibrin thrombi, I would look at it in a different way, that the as it is in a different milieu altogether, the autograft has done its action in quicker times.
Right.
It could be, it's possible, I suppose, because when we go through the other transplants that are done from one recipient to others, where the FSGS, dramatically, the proteinuria stopped immediately. The way it starts immediately in malignant FSGS and it has stopped immediately. So there are certain circulating factors which are constantly bombarding the transplanted kidney. When that bombardment stops, I think there is a possibility when it gets into a normal internal milieu, I think there is a possibility. I don't need speculations, that's all. But I have the evidence now that. And when I looked at the kidney that day, I never thought this kidney would work because it was like the consistency was like a tennis ball. I have held hundreds and hundreds of kidneys from the donor before I have given it to the recipient side table. But they are so supple, and this kidney was, even after perfusion, it was turgid. Like if I had bounced it, it would have, I mean, if I had thrown it on the floor, it would have bounced it. It would have bounced. So I knew there was a lot of edema in that. A lot of infiltration must have been happening there. Then it just happened like that. I think there are some questions being asked there.
Yes, sir. So we'll take the questions from the audience. There's one question which asks, what were the implications and verdict of criminal and medical negligence cases in this case?
So what
If
happened
you are
is,
happy to share it and comfortable
yeah,
sharing
what
it
happened
here.
is, I said that's why I thanked my hospital administration. They got into the negotiation table. Multiple negotiations happened. I think they settled it for something, and they withdrew all the cases. But the government inquiry went on. We all had to appear in front of the inquiry committee. One of them was a non-clinician who held on to this Himalog clip, FDA black box warning. But then we had to produce the literature and the response from all the transplant centers who are doing lab donor nephrectomy. They all still used and are still using Himalog clip. So there were few nephrologists and urologists who were active in transplant. They all gave a favorable opinion saying that it was not an intentional negligence as such. There was no intention for the party for us to cause harm to the patient. Then the police case was also withdrawn, and they withdrew the case from the medical council. They were very, very loyal patients of mine. They were wonderful family. They didn't want to go anywhere other than me for the transplant because they were, at least on 3 occasions, she was brought to casualty in almost respiratory arrest. She was intubated timely, brought her out of pulmonary edema with dialysis and ventilation. So I think somewhere in their mind, it was still there that I had done some good to them. So they withdrew all the cases, and the government also gave a inquiry report also came out in our favor. That's what, otherwise it would have prolonged for another 12 years. Any case going to Karnataka Medical Council will not find the end of the story for minimum 10 to 15 years. So that's it.
So we have another question, actually 2 questions almost, which are asking the same thing, that despite a CDC and DSA negative post desensitization, how do we explain the ABMR and how do we explain the rapid reversal? I think we've already discussed about the reversal, but I think it's time that we discuss regarding the decision for going ahead with the CDC cross-match positive, and secondly, despite the CDC and DSA being plumb negative, why exactly should an AMR have happened in this case?
I think those who are in active transplant program, we know that most of the cases we do are not even historically positive cases.
Right.
They are negative and they are DSA negative, but still we do come across antibody-mediated rejection. It's not uncommon. It's quite common now of late. or even earlier it was there. So it's not an unheard of situation. Sampath should be able to highlight on that. ABMR, acute ABMR is not uncommon that way.
Yeah, we
So
do
these
have. No, we do now that we are looking more closely at non-HLA antibodies also. So these are all things which come up rarely. So like the angiotensin 2 receptor antibodies, they're all now being recognized. And it was not common knowledge at that time, 12 years ago.
Yeah, even like
They have the
in the
anti-endothelial
early,
antibodies.
Mahesh is the one who reports almost all our biopsies in Karnataka. He should be able to highlight. Yeah. How often do you?
If we look at the incidence of AMR versus the ACR in the early transplants, now the things have changed. Like the ACR is almost unheard of in the initial period. So all that we are more concerned or more findings that we see is that of microvascular injury, and if there is any aggressive nature, so the TMA also will be one of the finding. So microvascular injury is all that in the early transplants that we focus on as of the current trend. So AMR is always at a risk that we have to see in the early period.
Right, sir.
This patient I had sent when the AMR diagnosis happened, I sent the blood again for donor-specific antibodies in the recipient. And then all this was happening, I lost track of that sample which was sent to Chennai. Later on, when things sort of settled down, when I inquired, unfortunately, the courier fellow had given it to the blood bank instead of transplant immunology. Then they didn't know what to do with it and they had discarded the sample. That would have given us some idea. I also didn't pursue because there was a lot of commotion going on mentally, emotionally. A lot of things were happening. It was like a war zone. The hospital was like a war zone.
Definitely, sir. Dr. Himanshu, sir, I would like to ask you one question which has been discussed actually before. That do you personally have any threshold for desensitization? Like at what MFI do you actually prefer to desensitize patients and go ahead, or do you rather prefer an alternate donor or a swap in such cases?
Yeah, actually the same thing as Sir has highlighted this case. So things can happen. Whatever is written in the literature, that can happen. This case showed the same thing. And as far as I think live-related transplants, they are more risky transplants as compared to the disease donor transplants because there you have a cadaveric kidney. So if the DSA is positive, I think even if you desensitize, there are higher chances that the antibodies return back because the memory B cells are there. But as far as MFI is concerned, if the flow cross match is positive, CDC is negative, then we need to decide if the MFI means if you do DSA, now there is higher resolution HLA, so you can just pinpoint which antibodies are in the significantly higher. So I think we're below 1000, there is no need to desensitize if the CDC is negative. But up to 5000, I think we can desensitize the patients and we can go ahead with the transplants with ATG as induction agent.
Right. I'm sure everybody has their own threshold, but I think it varies from center to center. There was one more topic which we wanted to discuss with Dr. Mahesha, which was regarding Dr. Gurudev had mentioned regarding two other cases of FSGS and TMA, which were retransplanted into different recipients and resolved completely. So, sir, are there any other such opportunities which we have apart from FSGS and TMA where the internal milieu is the reason for the disease, and we can consider retransplanting into a Although the case where we are retransplanting into a donor is of course going to be very, very rare.
Yeah, there will be scenarios where in the deceased act, especially the deceased donor, if there are instances like the urine protein is positive in a, say, for example, diabetic patients, or if there is any hematuria in the ICU patient who is to be declared brain dead and possible donor. So in those instances, when we do get the biopsies for evaluation of the histology per se, to see if there is any diabetic lesions or if there is any IgA in the deceased donor. So if the renal function is normal, or if the histology, especially the tubulointerstitial compartment and the glomerular chronicity, is not at all present in the biopsy, if there is just subtle expansion of the mesangial matrix and you do the immunofluorescence on priority, we have ample amount of time when in the deceased donors scenario. So the immunofluorescence would take almost 1.5 to 2 hours. So that is permissible in that transition of procedure. So even if we get a diagnosis of IgA nephropathy, so that should not be a reason for rejecting the kidney. Similarly, in diabetic patients, if there is no chronicity and if there is only mesangial expansion with a proven record of blood sugar being elevated in the deceased track record. So that those kidneys should not be rejected. Even the literature says that the KW lesions can be reversed in a recipient, because it's the milieu that is more important rather than what disease it has in a subtle phase. So IgA and diabetic, I would say these two are other scenarios when it comes to accepting the kidneys from the deceased donor. Like in the live donations of family or the donors who subsequent in the recipients, we do get an indicated biopsy, and if the in the immunofluorescence, sometimes we get the mesangial IgA deposits. So that's nowhere related to the recipient disease, even if done in the early period. So that's all derived from the donor. So in the subsequent biopsies for IgA, at least I have a couple of patients who have been done as indicated subsequently, but the IgA deposits has vanished in the further biopsies. So that means that the milieu is more important rather than the disease in a subtle phase in the donor graft. So these two are the other scenarios where milieu is important.
Thank you very much, sir, for telling us regarding that, because I think it's
Very
very
important.
important.
That's a very important point Mahesha has brought about, because see, many patients who are we find HbA1c of 6, but they don't have 6.2 or 6.5. They are never found to be diabetic till then. Only when we are evaluating as donors we find that. Actually, if we had done a biopsy on these donors, we would have definitely found some mesangial expansion or some deposits. Clinically, the disease may not be evident at that point. And as Mahesha said, there has been a case report way back in 90s in Kuwait when they did a transplant from a diabetic deceased donor. Biopsy proven KW lesions had completely disappeared in the recipient after some time.
So I have two such cases of diabetic lesions with the KW in the pre-transplant evaluation. Dr. Anil from BGS Hospital is a nephrologist. So I have convinced, and we discussed a lot about this case report that sir had mentioned just now, and he has done the protocol biopsies on a curiosity basis, convincing the patient to get the biopsy procedure done. So there is no further progression of disease in the subsequent protocol biopsies. So in the KW lesion, which was there in the pre-transplant, has been in the first protocol biopsy. But in the second, I could not find the KW, but there is definitely the expansion of the mesangial matrix is still there. So, and the chronicity is never an issue in the subsequent biopsy. So that adds on to the point that the progression of the diabetes is not happening in the recipient.
Right. So we'll take one last question, which is a very interesting question, is that considering the possibility of passenger lymphocyte syndrome and considering that donor lymphocytes were definitely present in the explanted kidney, was any immunosuppression given to the donor? And do you think these lymphocytes could cause any problem when retransplanted in the donor?
I think it is a highly theoretical possibility because the life of the passenger leukocyte is going to be very short, and if at all major graft versus host disease to happen, you require long-standing generation
Production.
of these lymphocytes. It's going to be a transient affair.
Right, sir. I think we've already exceeded our time and we should close this excellent session. Thank you very much, first of all, Dr. Gurudev, for sharing this excellent case with us, which has been a learning case for each one of us present here. Dr. Sampath Kumar, Dr. Mahesha, and Dr. Himanshu for your excellent insights, and to all the audience for their involvement and their questions for this session. And I would like to thank Dr. Manish Balwani and Dr. Arpita for starting this excellent initiative for the education of transplant physicians and surgeons. With that, I would like to end the session. Thank you very much, everybody, and hope to see you soon.
Thank you.
Thank you.